Welcome to BFR Radio, a podcast dedicated to all things blood flow restriction training. This podcast is proudly sponsored by the BFR.co, where if you want to buy your own BFR cuffs, access online BFR training programs, increase your own BFR knowledge with the accredited BFR.co course, or you want more information about this type of training, this is your one place to go. And I'm your host, Dr. Chris Gavilio. Welcome back to BFR Radio. Hope you're doing well. The last episode was an article review which focused on the use of BFR in the early stage rehabilitation following ACL injury. This was a great article that highlighted the many uses of BFR in the acute rehab stages. With the sporting season in Australia getting underway, I felt this was a timely article highlighting the power of BFR to improve the outcomes from ACL surgery. Irrespective of the time of the year and country, ACLs are a prevalent injury that is always topical. If you're hearing this for the first time or you know of someone who has gone through ACL surgery and they don't know anything about BFR, let them know about the podcast. I'm always happy to chat to people, so connect them with me, or alternatively, maybe a live podcast where people can join in, maybe another option. Let me know. Now, this episode is taking a little while to get out. Firstly, the reason for the long delay in between episodes, aside from having some free time to put this episode together, is that, as you may be aware, I work with world-class decathlete Cedric Dubler. As this is an Olympic year, he is trying to qualify for the Paris Olympics. You can qualify via two methods. One is to achieve the automatic qualification standard, in this case, a score in the decathlon. Or alternatively, if you don't achieve the auto qualify, you can get ranking points. In the pursuit of chasing qualification, he unfortunately injured his hamstring. Now, this is a podcast episode on its own. However, as a teaser, he injured his hamstring whilst competing in Fiji. Flew back to Australia, he got an MRI. It was diagnosed as a hamstring tendon rupture. That's the long head of the biceps femoris, which is a 4C classification, the worst you can get. And also a 3C musculotendinous tear, which also isn't very good. Due to a multitude of factors, we decided to go a conservative rehab route instead of surgery. In addition, at the end of week 2 or start of week 3 post-injury, he flew to Germany to see world-renowned Dr. Hans Muller. And this is another fascinating episode just on its own. They informed Cedric that his hamstring wasn't ruptured. And after a week of treatment, they informed me that he could actually compete at the end of that weekend. And throughout this period, Cedric was actually quite functional, which was interesting on its own. And we'd actually been training and progressing his strength and his running. Therefore, at the end of week 3, he went to compete in Germany. Although he competed, his hamstring wasn't ready to run quick, and we only did about 5 or 6 events. So then, as the very last opportunity, we went to the UK. Now, what we achieved in the 4 days between the Germany competition and the UK competition was absolutely amazing. And in the UK comp, he felt his hamstring in the first event and pulled out. Interestingly, no lingering issues with the hamstring, and straight away he was actually able to jog and walk okay. It just wasn't good enough to compete at an elite standard. Irrespective, an amazing journey nonetheless, and this has kept me busy the last few months, and hence no episodes since. I'd love to do a podcast on this, or even a live Q&A type presentation. Cedric has mentioned he'd be keen to be involved. If you like the idea of this, let me know. And further to that, if you have specific questions, shoot them through to me as well, and we can incorporate that into the live Q&A podcast. Now back to today's episode, and this is related to tendon ruptures. At the time, I was watching an Australian rugby league game, and a very prolific player suffered a distal biceps rupture as he was going for a tackle. Nobody likes to see athletes get injured. Therefore, I thought I'd see what I could find about BFR and bicep ruptures and put together a podcast for you. There's not a lot out there, but I could find one paper on this topic. And for today, it'll form the basis for this podcast. The article is called Post-Operative Rehabilitation of the Distal Biceps Brachii Tendon Reattachment in a Weightlifter, a Case Report. Although the athlete in this article was a weightlifter and the athlete in question was a rugby league player, there are parallels with the surgery and the rehabilitation process. Firstly, let's get an understanding of this injury. A distal biceps brachii tendon rupture is an uncommon injury that accounts for only approximately 3% of bicep brachii tears. Bicep tendon ruptures, particularly at the distal end, which is near the elbow, are significant injuries that disproportionately affect athletes engaged in strength training and also in contact sports. More specifically, it is the biceps brachii which ruptures, and this is an anterior muscle composed of two heads which bridge the shoulder girdle to the forearm. The distal bicep tendon from the two heads may converge or remain anatomically separate before they attach to the radial tuberosity. And this radial tuberosity is the bony projection on the medial or the inside surface of the radius, which is one of the bones in our forearms. The rotation of the biceps short head primarily helps with elbow flexion strength, while the biceps long head primarily provides supination strength while the elbow is in a flexed position. Supination in this case is a movement that enables you to rotate your palm upwards and outwards. In simple terms, it's how strongly you can turn your hand from a palm down position to a palm up position. These ruptures are typically seen in sports that require forceful contractions of the biceps, such as weightlifting, bodybuilding, and certain contact sports like football. The nature of these activities often leads to acute traumatic injuries where the bicep is suddenly overloaded. For instance, among weightlifters, these ruptures can occur during heavy lifting when the elbow is forced from a flexed to an extended position under load, creating excessive tension that overcomes the tendon's intrinsic strength. The standard treatment for distal bicep tendon ruptures in athletes involves surgical reattachment of the tendon to the radial tuberosity, which can be achieved through several techniques, including a single incision or dual incision method. These surgical interventions are crucial for restoring the original anatomy and function of the bicep, particularly supination and flexion strength. Following surgery, athletes typically undergo a structured rehabilitation program designed to gradually restore strength and flexibility. This program generally spans several months, starting with gentle passive movements and advancing through stage reintroduction of load-bearing and strength exercises. Athletes can often return to full activity within 4 to 6 months post-surgery, depending on the success of the surgical repair and the adherence to rehabilitation protocols. In the case of this person in this article, it was a 35-year-old male weightlifter who was also a strength and conditioning coach, who presented 5 days post-op after the reattachment of his left distal biceps brachii tendon following a traumatic full rupture of the structure. The injury occurred while spotting a client during a push press exercise. While spotting the exercise, the client let go of the bar during its descent, and the weightlifter reflexively grabbed it with his arms above 90 degrees of forward flexion and the elbow at full extension. The weightlifter experienced an immediate, sharp and audible tearing sensation with mild to moderate swelling in the left cubical fossa. During the initial consult, the weightlifter reported his pain was on a 5 to 10 on a numeric pain rating scale and characterized it as a deep and profuse achiness with movement and also at rest. The weightlifter reported a marked loss of left elbow forearm and grip strength and mobility and occasional cramping in the forearm flexors and extensors since the operation. There was other clinical measurements taken to assess the ability and performance of the elbow for a pre to post-surgery comparison. After surgery, the weightlifter underwent an accelerated recovery program for 15 weeks to provide a full and unrestricted activity of the affected limb long term. Several complementary therapeutic modalities were also implemented in this rehab program, including kinesiotaping, laser therapy, scar mobilization, and functional range release techniques. Now, this was also to promote tissue healing response and improve the integrity of the affected area. A kinesiotaping application was applied in an attempt to promote lymphatic drainage in the area. Laser therapy was also applied along the incision sites and the attachment point of the biceps brachii tendon during the first 10 sessions. Laser therapy is a non-invasive treatment that can be safely combined with other post-operative treatments without the risk of drug interactions and can be highly beneficial for several reasons. Firstly, accelerated healing. Laser therapy can stimulate cellular activity and increase blood flow to the surgical site, promoting faster tissue repair and wound healing. Pain reduction. This treatment can help decrease post-operative pain by interfering with pain transmission and stimulating the release of endorphins. Also, inflammation and swelling reduction, which can lead to faster recovery and improved patient comfort. It can help with improved range of motion by reducing inflammation and promoting healing, which is especially beneficial for joint surgeries. Soft tissue therapy using functional range release techniques began 3 weeks following the initial appointment once the bruising and swelling in the arm and forearm were no longer present. Functional range release is a hands-on method of assessing anatomical structures through palpating at tissue, appropriate depth, and tension at rest, and through movement to delineate between healthy and uncharacteristic or irregular tissue motion. Soft tissue treatment initially begins as scar mobilization and was then gradually applied to the other affected upper extremity tissues, which most commonly presented in the anterior aspect of the arm and anterior and posterior aspect of the forearm. The exercise prescribed during the first 7 weeks of the rehab program encouraged maximal range of motion of the upper extremity articulations, provided the movements elicited no more than mild discomfort around the surgical site. Emerging evidence supports early and unrestricted movement of the elbow following uncomplicated distal bicep tendon repairs. Aggressive post-operative rehab of the injury is also advocated for an accelerated return to full activity and is reported safe during uncomplicated tendon repairs, given that the repair strength is greater than the force produced by an unweighted forearm. It is generally accepted that subjecting the distal biceps tendon to external load should be kept to a minimum in the early stages of rehab, so that the reattachment site has time to heal. External loads of greater than 5 kilos was introduced by week 8, despite the surgeon's recommendations for a 5 kilogram weight restriction until 12 weeks post-op. This decision was multifactorial and largely based on both the safety profile for introducing external load by the 8-week mark and the patient's determination to start strengthening the affected area earlier than the surgeon's recommendation. For BFR training, this commenced 3 weeks post-operation in an effort to decrease the loss in bicep strength and also in the mass as a result of the post-op weight reduction recommended to the weightlifter. In this, they utilized the 75 rep protocol, where over 4 sets, they performed 30 reps, followed by 3 sets of 15, all with a 30 seconds break. The weightlifter initially was required to complete the rehab protocol without the cuff and was to report no fatigue or discomfort before he was able to introduce BFR. The protocol initially began with no external weight in a wrist neutral position. Weight progressions and changes in wrist position are actually outlined in a table produced in the article. Without going into excessive detail, but to give you an overview, the weightlifter performed the exercises daily. Over the first 7 weeks, there was a progression of exercises that involved movement-based, these are called controlled articular rotations or CARs, and elbow flexion and extension over an increasing range of motion. Isometric holds at various angles in elbow flexion, like a bicep type curl over a 30-second time frame, were also used. Aside from an increase in range, volume appeared to be the progression over the 7 weeks. Isometric loading of the biceps tendon was using the opposite arm for resistance application, and this commenced during week number 4. By week 8, the isometric hold intensity increased up to about 10% of maximum, and more typical multi-joint exercises such as bench press and bent over row was introduced, 10 to 15 kilos only. From week 12 onwards, an additional 1 to 2 exercises such as barbell push press, single arm kettlebell deadlift, and barbell snatch were introduced. The loadings were kept low. Therefore, the progression in this program was rather through the introduction of more complex and multi-joint strength exercises. And as it was a case study, only outcome measures were reported, and there weren't any mechanisms measured. However, based upon literature, the authors proposed a few. Based on other research, one was a potential activation of the mechanistic target of rapamycin, or mTOR. This is a cellular pathway which is involved in cellular proliferation. In simpler terms, think of mTOR as a master switch in your cells. When this switch is turned on, it tells your cells to grow and multiply, which can lead to muscle growth and strength increases. And this is one of the many benefits of BFR training. And another mechanism is that BFR training during the early post-operative rehabilitation of the biceps brachii may also have a favorable effect on the reattachment sites where the tendon attaches to the bone. And this is due to increases in interosseous pressure, or the hydrostatic pressure within the bone. This is thought to occur through BFR training and may influence fluid shifts through the capillary networks found in bony structures. BFR training has been shown to impact bone healing properties through metabolic markers that reduce osteoclast activity. Osteoclast activity refers to the bone resorption process carried out by osteoclasts, which are these specialized cells responsible for breaking down bone tissue. Therefore, the ability to reduce osteoclast activity is really favorable. And as such, the BFR training can contribute to both bone resorption and formation. Another interesting observation noted in the article was that despite the lower load used for the BFR training and the marked reduction in the use of the affected limb due to the amount of weight that he could lift relative to pre-injury activity levels, the weightlifter reported the sensation of his injured non-dominant arm being larger than his non-injured dominant arm after 5 weeks of BFR training. The measurements of arm circumference was then taken, and it was actually shown to have a difference of 2 centimeters greater circumference on the left non-dominant or operated arm relative to the right dominant arm. This finding of muscle hypertrophy using low loads is consistent with other BFR training studies. Overall, this case study highlights a successful and accelerated rehabilitation of post-surgical biceps brachii tendon repair and makes use of the positive effects of BFR. Thinking further and understanding the other positive benefits of BFR use, I feel that there are a few additional ways to enhance this accelerated rehab program. The first is using the concept of contralateral strength training. This is where the positive effects of strength training on one limb can positively affect the other limb. As an example, in one BFR Achilles tendon study, which I've previewed in a previous episode, they looked at performing exercises, that's calf raises, on both limbs. In the BFR group, the participants wore the cuff on one leg only. In the control group, they did not wear the cuffs. In both groups, the participants performed exercises on both limbs. The outcome is that in the BFR group and on the leg where they did not wear the cuff, the participants had significantly better post-training results compared to the control group, which didn't wear BFR at all. How this would work in the case of the biceps is that in the first 3 weeks where there was no BFR used, I'd put the cuff on the unaffected arm and perform the same rehab program exercise on that arm as well. In other words, for the first 3 weeks, perform the same rehab exercises on both arms, but with the addition of wearing the BFR on the good arm. Further this, and based upon the greater increase in limb circumference in the operated arm, I would continue the rehab program for both arms. The second concept is high-frequency training. There are a multitude of training studies highlighting the benefit for performing multiple sessions a day. This is perfect for shorter time periods, say around 3 to 4 weeks. And if I was programming, once the BFR was introduced to the operated arm, I would increase the rehab program to twice daily at a minimum. In other rehab programs, more so soft tissue, I get athletes to do their rehab programs or get a BFR stimulus up to 3 to 4 times daily. Now, I note that this was tendon, not a soft tissue injury, and therefore performing high frequency training 3 to 4 times daily, I think can really accelerate the healing process. And another method is the use of passive BFR. This would be a nice introduction in week 2 or 3 before starting to use BFR actively performing exercises. Passive BFR has been shown to decrease the amount of muscle loss, although long-term, this actually was an issue for the athlete. But in some cases, the maintenance of muscle mass is very important in that early stage. Overall, this is a great example of how BFR training can be a suitable modality to improve patient outcomes and complement other aspects of their treatment when dealing with distal biceps tendon repair rehabilitation or rehabilitation for other conditions where low levels of external load are advised. Well, that's all for this episode. If you have any questions related to this, let me know. And also, if the idea of doing something with Cedric around the hamstring rehab protocols we've created interests you, get in touch with me through my website, which is thebfr.co, or my socials at thebfr.co. You can also purchase your own BFR cuffs from our website. And again, you can find that at thebfr.co. And lastly, before I go, a couple of favors from me to you. If you know of someone who would benefit from this episode, please share it. And if you are enjoying the podcast, please give it a rating on iTunes. Thanks for listening, and remember to keep the pump.